So I'm just going to introduce just our final speaker for tonight. So Dr. Christina Sibben is a neonatologist and has recently started working as part of the neonatal team at the Women's and Children's Hospital. She completed her fellowship training in New Zealand and at Starship Child Health and Flinders Medical Centre. And so just to kind of round out, we're now going to talk about the neonatal implications following or during cancer in pregnancy. Thank you, Christina.
Thank you. Thank you for that kind introduction. And thank you for the organising committee for asking me to talk tonight. It really is a privilege to be able to speak in this forum. So while I was preparing this talk, I drew on the experience that I had at Flinders Medical Centre. I completed my fellowship there and worked there as a neonatologist. And during my time there, we encountered two women who were diagnosed with cancer during pregnancy. One was a diagnosis for the first time, and the second was a recurrence of cancer. So I thought I would base my talk around those cases. So the mother I'd like to focus on in particular, she was actually diagnosed with breast cancer 8 years before, and she underwent quite intense treatment. She had a bilateral mastectomy, underwent chemotherapy and radiotherapy, and in her words, she followed every word of advice from her oncologist in terms of making sure that she got on top of her disease. She went into remission and the family decided that they wanted to have another baby. Unfortunately, over the course of her pregnancy, she developed some pain in her hip, which progressed, and she did present with symptoms to her carers several times over the course of the pregnancy. However, as we've heard from these women here tonight, the pain was put down to just symptoms of pregnancy. Unfortunately, she, at some point along the way, she met with a different GP, and he ordered some imaging of that hip, and they identified that she had metastatic disease. At this point, they underwent some further imaging, and she had widespread metastasis throughout her lungs, spine, and hip. And she was delivered the news that she had a very poor prognosis. So they allowed 2 weeks for the baby to mature and then delivered the baby at 32 weeks to facilitate her treatment. So what I would like to talk about is really the questions that I was asked from these two mothers when I counselled them initially. So one of the first questions that I was asked from the mothers and also from the nursing staff within the unit was, is there a risk that the baby the cancer will pass across to the baby? As we've heard already, cancer affects approximately 1 in 1,000 mothers who deliver a child. However, we suspect that number is probably increasing as we have advanced maternal age. There are 2 theoretical modes of transmission. That would be transplacental, and also in the case of cancer of the cervix, potentially a local transmission during a vaginal birth. There is very little evidence that to guide us in terms of the risk that the baby will be affected by that cancer, and it is largely restricted to case reports. However, in approximately 1 in about 500,000 mothers who are affected by cancer in pregnancy, the infant may be affected. There was a really nice summary that was published in the New England Journal of Medicine by this group by Aqua, and they summarised all of the known, or most of the known case reports and literature of transplacental passage of cancer to the fetus. There is variable amount of detail within these cases, but in this table here that you can see that these mothers who were affected with leukemia and lymphoma, their children were diagnosed with the same cancer at variable ages. What is quite challenging is that a lot of these children were not diagnosed in the neonatal period. They were actually diagnosed quite a bit later. So you can see that some were diagnosed at 4 weeks of age, whereas some were diagnosed at 20 months. There are a few more reported cases in the literature of women who are affected with melanoma, and this cancer passing across the placenta to the fetus. And again, we have a variable age of presentation for these cases. Some were present at birth and others were as late as 8 months of age. Unfortunately, many of these mothers succumbed to their disease, and there was a high rate of fatality amongst the affected infants. There are reported cases of other cancers transmitting across to the baby, and these include small cell lung cancer, adenocarcinoma, and other cancers of the cervix. The two cases that we're focused on in this review, they underwent next generation sequencing, and they found that the children had the exact same cancer that the mother was affected with. And as you can see in the last case there, this child was not diagnosed until they were 6 years of age. So this puts us in a really tricky position, because for one thing, I think the risk of the infant being affected with cancer is exceptionally rare, and the infant may not present with symptoms at birth. The symptoms may not become apparent for many months or many years. So we have little evidence to guide us to whether we should be screening these infants to see if they are affected with cancer from the mother. The next question that I was asked by these mothers and also by the nurses was, can we provide breast milk for the babies? As I'm sure I don't need to tell you all, there are a very long list of benefits of providing breast milk to these babies, particularly those that are born prematurely and are managed in our neonatal intensive care. However, we have very little evidence about whether or not it is safe to feed babies from mothers who are undergoing treatment. So we know that cytotoxic drugs are likely to be excreted in the breast milk. However, this does vary from agent to agent, and it really depends on the lipid solubility of each drug, the molecular size, and the most important factor is actually the concentration, the half-life in the maternal plasma, and this varies greatly from drug to drug. We know there is a theoretical risk to the infant. However, this is based on the amount that is absorbed by the baby from the oral route, the bioavailability, and the metabolism in the infant. What is also of concern is the local toxic effects to the gut of those particular drugs. We have very little evidence to guide us as mothers who are breastfeeding are most often excluded from chemotherapy trials. And the evidence we have at the moment is largely based on small case series or anecdotal case reports and is mostly theoretical. When I spoke with this particular mother, she was really upset. Breastfeeding her child was very important to her, and it made her feel fairly worthless to not be able to provide her infant with breast milk, particularly as she was a baby that was born premature. So we dug a little deeper into this and talked with our pharmacist at the hospital. And we know there is emerging literature on the specific chemotherapy agents and radiotherapy regimes. And we're gathering more and more evidence about how much of the concentration of a particular drug is excreted in the breast milk and for how long. There is some information about the oral absorption and the potential toxicity to the infant. So I think it is important to at least consider this. I think in the past it has been largely ruled out as unsafe, and it is difficult to gather a lot of evidence because it would be unethical, really, to expose infants to mothers' breast milk that are undergoing chemotherapy to see if there are any toxic effects. However, there is an opportunity to breastfeed in between cycles. And I think with discussion with the pharmacy at the local hospital, we can delineate exactly how long that chemotherapy agent will be present in the mother's bloodstream and in the plasma, and potentially affects the infant. And there is an opportunity to breastfeed in between. The next issue that I would like to raise is the intense emotional distress that these women faced in the neonatal intensive care unit. So this woman in the case, she was facing cancer for the second time and was told that her prognosis was poor, and so she knew her time was limited. On top of that, she had delivered a baby prematurely, and this baby happened to be really sick. This baby was really unwell in intensive care. She was ventilated she was in 100% oxygen, and in all honesty, we weren't quite sure if she was going to make it. She was actually quite unwell by this point, and she had begun treatment at the Royal Adelaide Hospital. And the father was left at the bedside beside the baby. So this put this family under enormous amounts of strain. This mother was transferred to the Royal Adelaide Hospital, and she underwent intense chemotherapy immediately, and she was being prepared for a stem cell transplant. So it was not actually possible for her to physically be with her baby during this time, and we relied on her partner and extended family to provide cares for the baby. And the challenges that we face is that this was unlikely to change anytime soon. She was likely to be isolated for some time and was facing side effects from her treatment, which were fairly overwhelming. The family were not from Adelaide, and so we faced issues with transport and accommodation. In addition, they had an older child, and with limited family support, childcare became a problem. There are financial implications, as neither parents can now work. And I think the cases that we see in the neonatal unit will really depend on the amount of family support that can be offered. So in discussion with her and the other women that we treated last year, I asked her what could we do that would be more helpful in the future. And her first suggestion was liaising with the Cancer Council from an early age, from an early time in the course. The social worker that was involved with the case had offered her fairly limited resources, and she was left to source these resources on her own. She found that visits from the Cancer Council can be enormously useful. They can provide assistance with finances, in addition to psychological support and practical resources that are specific to her particular cancer. There are an enormous amount of resources online for a cancer. So for her, an example, she had breast cancer. So there are an enormous amount of resources online that are available to her. And she found a rehabilitation clinic particularly useful. They have exercise programs, physiotherapists, occupational therapists that are specific for these women. In addition to that, they have dietitians that can support with them and psychology for herself, the couple, and the broader family. She mentioned quite a few times that she found the meditation services they offered particularly helpful. So in short, there was an enormous amount of allied health that she found helpful, but unfortunately these were not offered to her in the first instance at our centre, and I think that we can do better. One of the quotes that she said to me towards the end of the conversation was that she found that the nurses and the social workers that were involved with her care had enormous amounts of empathy for her, which is understandable, but that this was not particularly useful. What she really needed was somebody that could provide her with resources that actually could help her practically move through the situation. And I think that's the important thing to remember in cases such as these. And I think that we could offer these women more support, which would be helpful. And that's the end of the case. And I've just got a list of the references that I referred to in this talk. Thank you.